is a 12-year-old like Liz spoke about, or whether it is the 45-year-old woman coming in for that dreadful women's health check that she's been told she has to have by her male GP, who she's been seeing since she's a baby, then we really have to be mindful of who we are as a practitioner and how we operate. So I suppose these are just a few things that I have thought about in terms of what happens when someone comes into the room. So as a clinician, I've had the great privilege of being able to go and educate young people of all abilities in their own settings, in schools, in residential houses. Liz and I did a program for the VCAL students at Kalyana here in Bendigo last year around some of these topics. I've been one of the facilitators of the Living Safer Sexualised or Sexualised Respectful Relationships program that Kim was talking about. I've been a midwife for 30 years, so I've often worked with women who are pregnant and who have gone on to have their baby and look after them afterwards. And I've had lots of, maybe not necessarily positive experiences as a clinician, to be quite mindfully told by a teenage woman that they actually don't really like me and they want to go and see somebody else. So as a clinician, I have to really take that on board, because we are dealing with a very vulnerable group of people who really deserve us to be really honest with ourselves before we actually embark upon trying to provide them a service. So all these are just, I suppose, highlights of what we need to do in terms of when we work with someone in a clinical setting. So I use often a lot of non-verbal activities in terms of being able to really get within that first 15 minutes of someone sitting in the room with me about whether or not it's actually going to be a positive experience for them or not. And quite recently, a young woman who's 16, who's pregnant with her first child, who has a significant diagnosed intellectual disability, basically just got up and said, "I'm over this," and walked out. And I think I'd said three or four things in our big list of things that the guardians of her had wanted us to discuss in an hour. So you can't really do too much. You can't run down the corridor and say, come back, we need to keep talking about you being 16 and pregnant and 13 weeks and what you need to do. She was just over it. She was hungry. So that's the reality of working in a clinical setting. You would want, hopefully, that at some point in time they might come back. If they don't come back and see you, there needs to be someone that they can come and see. Our consultations, I suppose, we're very fortunate to work in a community health setting in that fact that if you go into GP land, you will know that 30 to 45 minutes is absolutely unheard of nowadays. So as people who work outside health care, if you are supporting or encouraging someone to have a conversation around menstrual cycle, leading up to puberty, how to use a condom, then you need to actually source a service that's actually going to be able to provide that time. When we look at assessments, we often with adolescents will use the HEADS assessment, which is a very well-known, well-trialled evidence-based assessment, which allows us to work within the parameters of those headings. But sometimes is it about what is the right question to ask? And for some people is that they're not actually worried about anything, but an appointment has been made for them by the person who is caring for them, their guardian, their case manager, the nurse in the clinic, or someone else has actually made an appointment. They're actually not too worried about it. They're not really sure what's happening with their day-to-day life. So sometimes for us it's, what can I do for you today? And they might say, I just want to know some information, or I'd like to know about something else that is actually not necessarily in that sexual and reproductive health kind of umbrella. It might be something completely different. So we have to be incredibly flexible, I suppose, as clinicians working in this space. People are probably very familiar with all the things that we can do if that's actually what is consented to do. And there has been numerous times where a young person, particularly a young person under the age of consent, has come into our service, and we have been told that that young person is not really engaging with us, not really wanting to say why they're here. The person in the room for the first part of the consult might actually say, do you want me to tell you why you wanted to come here? And the young person might say yes, but not even look at me or the worker, and they might say she's worried about being pregnant, or he's worried about a problem down there. So we may get to doing some clinical work, or we may not, depending on the consent of that young person, because often they arrive in front of the clinician really not ready or prepared that day to do anything, and we need to be mindful of that. But every opportunity for an educational information gathering, sharing, knowledge assessment and debunking the myths is really critical. So a successful consult for me is that whoever's come into the room, whether it's a young person with someone that they've consented to come into the room with them on their own, a session where there's a few people, then it would be what have we been able to learn today for myself, but also for them. Debunking this is really huge in terms of the clinical space. We've already heard about what happens when we don't get our message across and what they hear about the blood nose. So it's time and time. Often it is related to terminology. It's related to how our body works. Sometimes it's related to you can't get pregnant the first time you have sex, because that's what they've been told. So every time someone comes into the consult, it's an opportunity for sharing and gathering. And the gathering may be just because we know that nothing's going to happen that day in terms of a clinical activity, but hopefully there may be another opportunity for that to come along. So one of the things I just wanted to briefly talk about, because listening to the conversation when I came in today, was around cognitive deficits versus intellectual disability. And I would say that 75% of my work, particularly with young people, they have some kind of cognitive deficit, but they may never have been assessed with an intellectual disability. So they actually haven't had the assessment, because assessments are really tricky and really hard. And so they come in and you have to kind of work out where the process is not working for them in terms of their cognitive abilities. And it may be that they can hear what you're saying, but they actually can't process it and speak it back to you in a way that demonstrates that they've actually heard you, or that they can use very short monosyllable language as opposed to be able to demonstrate some more abstract concepts. Probably this is the most common issue that we work with, is in terms of people in their relationships. In the sexual and reproductive health arena, often people think we're only talking about intimate partners, but we're actually not. We're talking about relationships with everybody, particularly the people who are important in their lives for them to move on. So a lot of things we talk about is whether they understand the safety for themselves, safety for their partner, who they can trust and how to get help. Because we may not be the right people for them to have what they need. What is really important at the start of our conversation is that they don't have to tell us anything. There's no obligation for them to disclose, to tell, even if there is an indication that they need to. They don't have to get tested, and they don't have to start any medication. If it was the impetus that they're coming into the clinic to start contraception because someone says they're out there having intercourse with their partner, and it's a female and a male, and that they're the whole point of the consult was them to come in and have an education session around contraception, what they'd like and what they're going to start, is that it's their choice. And it's really critical that we understand that. As you know, consent is absolutely critical when working with anybody. In this arena, it is the most important thing. And as a clinician, And everybody here in the room, we know about the reporting issues. We know that we have to talk about really what they know and what they need to know. And so we really have to be quite unambiguous in terms of what we say. This is a really interesting component of our work, is actually trying to decipher consent versus regret. Because even in able-bodied people with reasonable cognitive abilities, it's grey for some people. And so people and individuals with intellectual deficits, we have to really tease this out. And sometimes it's really reassuring for them that we've actually teased it out with them so that they actually have a bit more of an understanding when we're talking about positiveness. Whoops. Positiveness in terms of relationships. And we've talked about being positive about our body, you know, loving our body, being able to express how we want our body to look and feel, and to be able to initiate intimacy if we want to talk about masturbation and to be able to be okay and not to feel that, you know, that's a word that we're not allowed to talk or only talk about in hush words. And so sometimes deciphering or teasing out consent versus regret is really critical in terms of empowering young people, particularly young people, in terms of taking charge over what they do and what don't want to do. And with regret and consent, of course, we need to talk about the legal aspects. And it's really reassuring for particularly a young person to understand that, you know, they may not necessarily be feeling happy about it, but it's not going to mean that there's going to be some legal issues if they talk to somebody else about that. Let's talk about how our body works. So naming it is really important. A story that I can talk about fairly recently with a very young 13-year-old female who came in for a contraception conversation, and I was like the second person that was discussing long-term contraception with this young person. She ended up being very comfortable with having an implant inserted after lots of discussion and education. And the reality is we were trying to work out where her status was in terms of her sexual activity. And it took us a long time to work out how to use the words. But in the end, we had to use the terminology that she used. So she hadn't heard the word vagina. She thought it started with B. She couldn't say penis. She just put her hands over her head like this. So I said, well, what words do you use? And she used the two most common words that we know. And we said, okay, so now today, this is the word for vagina. So we're going to use that word, and the word that you're going to use, which you call it a dick, we're going to call it a penis. And after that, she was okay. So we took it away from that. So in that little space, we were able to then, I suppose, educate her that it's okay to use those words, that it's not dirty to talk about using those words. Probably a lot of people would think this is what we do all the time, is just talk about how to prevent pregnancy and how to introduce contraception, so particularly for all the females out there, that their risk of unplanned or unwanted pregnancies we're going to be able to prevent. However, right at the start, we talk about rights. We talk about reproductive rights, because that's really important for women to know that. Even if they go on to choose to take on a contraception that's actually going to mean that they have very little chance of having an unplanned or unwanted pregnancy, they have that right. We talk about the types of contraception, and I suppose we certainly talk about the what ifs if a pregnancy does occur. And for most people now know that unplanned or unwanted pregnancies, you know, the options in terms of ending those pregnancies, we've got greater options in our area now with medicine terminations or medical terminations, as well as the surgical option through the Bendigo Hospital. And of course, the other obvious clinical discussion that we have multiple times is discussing STIs, testing for and discussing prevention. So we talk about a whole range of understanding around what STIs are, how they're transmitted. We talk about how we test, and as I said right at the start, it's very practical, you know, the jars there, etc. We have all the condoms, and basically the demonstration is our resources that we have in the room. So a young man or a young woman or someone who's identifying as either, when they have a consult with us, there's always a conversation around how they could actually demonstrate that they can use a condom, and that's really important. A couple of other things I just wanted to talk about was the discussion around enabling and empowering people with an intellectual disability to actually take control over their decision making. We've talked a little bit about it in terms of how we operate, but I think it's really critical that when we are in a clinical setting, we're not often the young person or the person with an intellectual deficit isn't often the one initiating the contact with us clinicians. It's coming from outside, and so it's really important for, as a clinician in a consult, that we're constantly reminding ourselves that it is the person with the client sitting in front of us, that it is ultimately their decision around how far or how much they want to do in that one consult that's important. And there's probably been numerous times that there's actually been a disappointment from the guardian, the educator, the residential care worker, that the outcome that they had wanted for their client hasn't been met. And we need to take that on board, because, as it's happened to me quite a few times, the next time this, particularly for a young female, has actually needed to come in for a completely different set of clinical needs because behaviour has occurred and now there's a concern. And as much as that's unfortunate, and I congratulate Liz that she's had such a 100% strike rate with her young women coming into her in achieving you know, not wanting to get pregnant and not getting pregnant, but sometimes the reality is it is that person's choice, and we need to be very mindful of that. So thank you, that's me.